Good evening to those who've joined. We'll be starting in just 1 minute. We're just waiting for people to join. For those who are joining, we'll be starting in just 1 minute. We're just waiting for Zoom to connect. We have a pretty big audience today, so we're just going to wait for everyone to join in. Good evening to those who are just joining. We're just going to start in a minute. We're just waiting for everyone to join in. It's a big audience today, and it'll take Zoom just a few minutes to link us all in. We have just over 2,000 people registered, and we're anticipating about 1,500 to 1,800 online. We're currently at just over 1,000 LinkedIn, so we'll be starting in just a minute. Okay, why don't we get started? Welcome everyone. I'm Mark Crowther. I'm the chair of the Department of Medicine at McMaster University, and I'm also the past president of the Anticoagulation Forum. Welcome to tonight's special webinar on vaccine-induced thrombotic thrombocytopenia, which is brought to you by the Department of Medicine at McMaster University, as well as the Anticoagulation Forum. I'm only going to do the very quick introductions, but just a couple of quick business items for today's webinar. First of all, we will have time at the end for questions and answers. Please enter any questions or questions you have in the question and answer box. If they can be dealt with in real time, we'll try to do that. We anticipate having a lot more questions than we're going to have time to deal with, so please put them in the question and answer. The chat function is available, but we will lose questions that are put in the chat function, so please put them in the question and answer. There have been many questions about whether this will be recorded. It will be recorded, and it will be available on the Anticoagulation Forum website starting tomorrow, and information about that will be shared later. If you have any technical problems, you can ask questions in the chat function, and we'll be able to help you as best we can. So without any further ado, I'll introduce today's host. Dr. Donnie Arnold is a faculty member here at the Department of Medicine at McMaster University, is an expert in platelets, platelet function, and is going to take the lead in running today's webinar. Dr. Arnold.
Thanks so much, Mark, and thanks to the Anticoagulation Forum and McMaster for hosting this event. It's really my pleasure to be speaking with you today and acting as your host and kickoff speaker. My name is Donnie Arnold. I'm a professor in the Department of Medicine at McMaster University, hematologist, and co-medical director of the Platelet Immunology Laboratory here at McMaster, which you'll hear more about later. Today, it's my privilege to be talking to you about a vexing new disorder that has cropped up in the last few weeks called vaccine-induced immune thrombotic thrombocytopenia. We have a packed agenda with an incredible expert panel of speakers who you will meet shortly, and I will introduce them soon after I speak. I'll start off the introductions so that they can get started in their talks. So here's what we're hoping to cover in the next hour or so. I'll kick off with the clinical presentation of VIT. We'll follow that up with Dr. Nair's report of the US FDA's reports of cerebral sinus venous vein thrombosis from vaccine in the US. Dr. Nazy is going to talk about testing for VIT. Dr. Warkentin is going to talk about parallels with a familiar disorder called heparin-induced thrombocytopenia, and Dr. Pai will close with practical approaches in diagnosis and management. Let's start off with clinical presentation. Firstly, I have no conflicts of interest to disclose related to this talk. Vaccine-induced immune thrombotic thrombocytopenia is a new disorder that's been just described in the last few weeks, characterized by the development of low platelets, as well as thrombosis that tends to occur in unusual locations. This occurs about 5 to 24 days after vaccination with COVID-19 vaccines. And the two vaccines that have been implicated in this disorder have been the AstraZeneca vaccine and the Johnson & Johnson Janssen vaccine, both of which are adenoviral vector DNA vaccines. So keep your eyes on the bottom citations, as you'll see things have evolved very quickly. So the first report of this syndrome occurred April 9th in the New England Journal. This was the first report from Germany and Austria of 11 people who had received the AstraZeneca vaccine. And what was most striking about this occurrence was that these were relatively healthy people who presented with thrombi in unusual locations. And that includes cerebral sinus vein thrombosis in 9 out of the 11 people, splanchnic vein thrombosis, pulmonary embolism, and arterial disease in one of them. Many patients had evidence of disseminated intravascular coagulation at the same time. This group of people were generally young, so the median age was 36, with an age range from 22 to 49. 82%, or 9 out of the 11, were females. They all had thrombocytopenia that was moderate to severe. The median platelet count nadir was 20, with a range of 9 to about 100. Occurred 5 to 16 days post-vaccine. Although the similarities were striking with heparin-induced thrombocytopenia, none of these people had received heparin, and 5 out of the 11 of this cohort died. In fact, the similarities were so striking with HIT that the investigators, just to rule it out, had done a HIT test, and the HIT screen came back positive in just about everybody. And the subsequent functional assay looking at platelet activation was also positive in all of those folks, including additional samples that were collected afterwards. The second report, same date in the New England Journal, April 9th, from Norway. This was 5 additional people who post AstraZeneca vaccine developed a similar syndrome. These were healthcare workers, 7 to 10 days after vaccine, ages 32 to 54, 4 out of 5 were female. The platelet count nadir similarly low, 14 to 70. CSVT reported portal vein thrombosis, and 3 out of 5 died. A similar laboratory profile, positive anti-PF4 antibody assays in all 5 of them, and positive functional tests in 4 out of the 5 people. The third big cohort was described a week later from the UK. This was 23 people post AstraZeneca vaccine, 6 to 24 days after vaccination. Again, CSVT, this time arterial thrombosis, a little bit more represented, pulmonary embolism, similar age groups, mostly female, and similar platelet count ranges, also with evidence of DIC, and 30% of that cohort was died as well. This was interesting because in 9 out of the 23 people in this cohort had a negative rapid HIT screen, although 22 out of the 23 were positive in the HIT ELISA. So we're going to talk about testing in a minute, but one of the nuances that hopefully we can take away from this is that not all rapid HIT tests are equal. And in this disorder, it's the anti-PF4 antibody, the HIT ELISA, that is most reliable. 5 out of the 7 that were tested were positive in the platelet activation assay. So what is possibly happening here? We're certainly seeing unusual thrombi in patients with thrombocytopenia. The mechanism is thought to be that for whatever reason, the vaccine causes a brisk pathological immune reaction, similar to heparin-induced thrombocytopenia, whereby antibodies are produced to platelet factor 4, which is a normal occurring protein within platelets, and for whatever reason causes this immune reaction to occur rather briskly. Once that antibody binds to PF4, it is then able to bind FC receptors on the platelets and cause intense platelet activation, resulting in thrombocytopenia and thrombosis. What is the frequency of this disorder? Based on the cohort studies that I presented to you, I'm going to say that answer is unknown. In the Norwegian paper, which has a different denominator, it may have been as frequent as 1 in 26,000. Others have proposed it may be 1 in 100,000, 1 in 250,000, perhaps in Canada were some numbers, and in the US with the J&J vaccine, it may be close to 1 in a million. So I'll say we don't know the answer to this. It's certainly rare, but really hard to get accurate denominator data. For my closing slide, I'll say this. The overall clinical picture is as follows, and the point here is that we need to be able to recognize this when it happens so that proper treatment can be instituted. This presents with aggressive thrombosis, mostly venous, but certainly arterial disease has been described, and usually venous disease or from thrombi in unusual locations. So cerebral sinus vein thrombosis has been quite common, splanchnic, hepatic, etc. Moderate to severe thrombocytopenia, 5 to 24 days post-vaccine with either of the adenoviral vector-based vaccines. Usually young females, but no obvious predisposing factors, and a 50% case fatality rate, which includes cases that had delayed recognition. And so one of the messages is really that early recognition is going to be key because treatment with a non-heparin anticoagulant and immune modulating therapies such as IVIG can be effective at helping folks with this disorder. So bottom line from the end of my talk is, if you see thrombosis plus low platelets, think of VIT. Of course, there are other disorders that can do that, but part of this is to raise awareness about this disorder. I'm going to move on now to our next speaker. And again, I'll reiterate what Dr. Crowther said is please include your questions in the Q&A box so we can address them as they come. It's our privilege really to have Dr. Narayan Nair with us today. He is the Division Director of the Division of Epidemiology from the Office of Biostatistics and Epidemiology in the Center for Biologic Evaluation and Research of the US FDA. Dr. Nair will be speaking to us today about reported cases of cerebral venous sinus thrombosis and thrombocytopenia after the COVID-19 vaccination in the US. Dr. Nair, over to you.
Thank you very much. Can I just get a sound check? Is my audio okay?
Yeah, you're good.
Great, thank you very much. And thanks for this opportunity to speak. Next slide, please. So this is just the disclaimer. These comments are in informal communication and they're my own best judgment. They don't bind or obligate the US FDA. And I was going to speak about the organization of the FDA a little bit, touch upon the source of these reports, and then go through the reports and the information that we have. But basically, this is the org chart for part of the FDA where I work, the Center for Biologics and Evaluation and Research, which is responsible for of the US, in the US of biologic and vaccine products. The Office of Vaccine Research and Review assesses the safety and efficacy of vaccines and makes a determination whether they should be approved or authorized for emergency use in the US. I work in the Office of Biostatistics and Epidemiology, and our focus is on the passive surveillance in my division and monitoring the safety of FDA-regulated biologic products and vaccines. Next slide, please. So, very early on, we became aware with the pandemic that a vaccine was coming, and we looked at how we would monitor the safety of the vaccine. And this system is what we use in the US, the Vaccine Adverse Event Reporting System. It's a national passive safety surveillance system. It's administered by the FDA and the CDC, and it was established in 1990. And it collects data from reports of adverse events following vaccination. Prior to 2021, we generally received around 50,000 reports, and they can be from anyone in the US, patients, providers, parents can submit a report, and they can be online or in paper. And data can be accessed actually by the public through CDC Calendar. And there's, it should be noted, it has its strengths and limitations. It's very good for open-ended and hypothesis generating. detecting new and rare adverse events, and particularly early detection of a rare adverse event. It's timely. We have geographic diversity. Anyone can submit a report in the US, and we can monitor to some degree production lots, but it's limited because these are spontaneous reports that are submitted. We may have missing or inaccurate data. We can have underreporting. Not every adverse event is reported, although with the vaccines in the United States, we did have mandatory reporting requirements for certain conditions. And also there can be stimulated reporting for people, if something's in the media, that may prompt people to report it at a higher frequency. We don't have a control group when we look at VAERS data, so sometimes it's difficult to assess causation. So next slide, please. So I wanted to touch upon the reports of CVST to VAERS after the COVID vaccines. And this information is as of April 12th, 2021. With the Janssen COVID-19 vaccine, we had 6 reports of CVST with thrombocytopenia, and this is platelet counts below 150,000. And this is following 6.86 million doses administered. So this gives us a reporting rate of 0.87 cases per million doses administered. With the Pfizer-BioNTech COVID-19 vaccine, we had 0 reports of CVST following the 97.9 million doses administered. With Moderna, we had 3 reports of CVST following 84.7 million doses, and this is a typo. All 3 of these reports had normal platelet counts, so they didn't fit this profile of CVST with thrombocytopenia. So essentially, this narrowed our focus to Janssen, and this was already a concern for us, the Janssen vaccine, because as was mentioned, the AstraZeneca vaccine experience in Europe, and our colleagues in EMA had noted that they had seen these reports of CVST and thrombotic events with thrombocytopenia. The AstraZeneca vaccine is not used in the United States, but the Janssen vaccine, both of these, as was mentioned, both of them contain this replication incompetent adenoviral vector. With the Janssen, it's the human variation of the adenovirus, but the chimpanzee is used with AstraZeneca. But there was concern with the similarity in these vaccine platforms that the safety signal could be possibly to occur in Janssen. In addition, with Janssen in the clinical trial before it was authorized for use, there was roughly 21,000 in the vaccinated group. There was one subject who did have this picture of CVST with thrombocytopenia. So for all the COVID-19 vaccines, we've been doing daily manual review. FDA physicians look at the serious cases we receive in VAERS every day. So when we saw these cases, it really raised our antenna. Next slide, please. And I wanted to go through the characteristics of what we've seen in the US with these patients. The median age has been 33. And again, these are the CVST with thrombocytopenia following Janssen. The range of the age was 18 to 48. The median time to onset of symptoms was 8 days with a range of 16 to 13 days. All of these occurred in white females. One individual was using oral contraceptives. None of these patients were pregnant or postpartum. In terms of pre-existing conditions, 3 had obesity, 1 hypothyroidism, 1 hypertension, 1 asthma, but none of them had any kind of coagulation disorders previously diagnosed. Next slide, please. And this slide sort of illustrates the initial and late signs and symptoms among these CVST patients. These patients aren't listed in any particular order, and they're de-identified, but essentially the initial features, really headache was the most prominent feature, although in one case it was back pain. And then in the late features, the severe headache, the headache became more severe, and in some cases they had neurologic symptoms, in one case abdominal pain or leg swelling, and that is typically dependent on the site of the clotting. Next slide, please. This slide shows the locations of the CVST, the intracerebral hemorrhage in some cases, and thromboses. And you can see for each patient where the CVST occurred. But essentially, it was in one case the right transverse sinus and right sigmoid sinus, but there were other locations as well. We had some of these patients that had intracerebral hemorrhage that varied on the right and left side, and one case was bilateral, and one case on the occipital lobe. 3 of these patients in these index cases of these 6 patients, 3 of them had blood clots in other locations. In one patient, it was in the portal vein and right pulmonary artery. In one case, it was the bilateral lower extremities, in one in right internal jugular vein, and in one in the portal vein. Next slide. And for these patients, they did have a SARS-CoV-2 viral test that was negative in all 6. SARS-CoV-2 serology to document whether they were previously infected was done in 3 of them, and it was negative in 3. Next slide. And then you can see that the hematology test results here among these CVST patients, the lowest, the platelet value, the lowest platelet value, the Nair was ranged from 12,000 to 127,000. The platelet factor 4 heparin-induced thrombocytopenia, this is the ELISA antibody test. It was not done for the first patient. For the remaining 5, it was positive. Next slide. In terms of treatment, 4 of these individuals received heparin following and then later were changed to a non-heparin anticoagulant. A platelets transfusion occurred in 3 of these patients. Intravenous immunoglobulin was used in 3 of these patients. And outcomes, all of these patients I mentioned were admitted to the intensive care unit and hospitalized. We had 1 who died, 3 at this point, and this is information from, I guess, late last week. 3 remain hospitalized, 2 in the intensive care unit, and 2 were discharged home. Next slide. So that's a brief summary of the U.S. experience. We are continuing to monitor this very closely to see if there's additional cases that'll pop up. We have put a pause on the Janssen vaccine in the United States, and further decisions are forthcoming. I wanted to acknowledge my colleagues at the Division of Epidemiology. We have a close collaboration as well with the CDC Immunization Office, and Dr. Shimabukuro provided many of these slides as well from presentations he has given. So that's all the questions I'm sorry, that concludes my presentation. I'm not sure if we're taking questions at the end or now.
Thanks so much, Dr. Nair. Really a privilege to have you here and get your perspective on a rapidly evolving situation in the US as well. We'll take questions at the end formally, but there's a lot of great questions happening in the Q&A, which all of us are kind of typing furiously to try to answer as they come. We touched on this a little bit already, and there have already been a few questions about testing. So the next segment is going to be around how do you test for VIT? And to answer that question, it's my pleasure to introduce Dr. Isaac Nazy. Dr. Nazy is the scientific director of the Platelet Immunology Laboratory at McMaster and associate professor at the Department of Medicine at McMaster University. He's also the co-chair of the ISTH Platelet Immunology Scientific Subcommittee, and in that work has led the development of ISTH recommendations on clinical and laboratory diagnosis of VIT. Isaac's also been instrumental in developing the functional VIT assay for our lab, and he will certainly be talking to you more about that just now. Dr. Nazy, over to you.
Thank you, Donnie. Can you just tell me that my slides appear properly?
Looks good and sounds good.
Excellent, thank you. So thanks for that generous introduction. So as Donnie mentioned, my name is Isaac Nazy. I'm the scientific director of the McMaster Platelet Immunology Lab, where the diagnostic testing for vaccine-induced clotting is taking place for Canada. I'm going to go through the procedure on how to get us the samples, on what type of tests we're using, what our testing algorithm is. I'm going to show a case of one of the samples that we tested, and there. So just really quickly, I have no financial or non-financial conflicts of interest to declare in regards to this talk. So I'll dive right into the approach that the McMaster Platelet Immunology Lab has set up nationwide to diagnose suspected VIT cases in the country and subsequently report the results to physicians and aid public health in tracking these adverse effects. So with the help of from public health and various communication channels, physicians across the country have been advised that upon the recognition of a possible vaccine-induced clot, to immediately draw blood samples before the initiation of therapy. They can go to our website at the McMaster Platelet Immunology Lab find the VIT tab under the test provided, and download the requisition form. We ask that they also include some clinical information in the requisition form as indicated in there, and samples should be immediately shipped to our lab for prompt testing. If physicians have access to a screening test, which is one of the type of tests that I'll be talking about later on, we'd like to know what their initial results are. And the reason for that is not all screening tests work equally. And in fact, some like the rapid immunoassays don't seem to detect any of these VIT-associated antibodies, as Donnie has already mentioned earlier. So there's two types of assays that we're using. The immunobinding assays, which basically tell us if the patient has any of these antibodies in their circulation. And the second type of assays are the functional tests, which tell us if the antibodies in the patient's circulation can actually activate platelets. And this is important to know, since this is the prevalent mechanism for these vaccine-induced clots as we currently understand them. So the immunoassays are used for the detection of platelet antibodies against platelet factor 4, or PF4, or PF4 heparin complexes. And these assays are widely available. So basically in these assays, we're detecting the presence of antibodies that are specific to either antigen. And in this example, as we can see in the figure, we have an enzyme immunoassay, or an EIA, or an ELISA, which involves coating a test plate with the antigens, be it PF4 or PF4 and heparin. And then we add diluted patient serum to the well and we wash it away. The only thing that will stick to the plate at that point and hence be detected are the antibodies if they're specific to PF4 or PF4 heparin antigens. These assays are commercially available, as I've mentioned, and they're routinely used at most medical centers because of their technical ease, rapid turnaround time. As for the preliminary data that we've seen worldwide, these tests seem to have a high sensitivity, which means that if the person does not have any antibodies, then they don't have VIT, at least the VIT caused by these specific antibodies. We don't know if these assays suffer from a lack of specificity yet, but we're working towards determining that number. If these assays start detecting antibodies in patients who do not have any platelet activation related to VIT, then the specificity will drop, and this test will be rendered useful to only exclude the disease in the absence of the antibodies. So this would be a scenario similar to HIT. So far, it seems that when the test is detecting antibodies, they have a very high correlation with platelet activation. However, this is based on limited samples. It's very important to know, as Donnie had mentioned previously, that the rapid immunoassays, such as the PGIA and the CLIA, don't seem to work very well, if at all. This is why we ask the referral centers to inform us about the tests they are using and the results they're getting, if they actually use a screening tool that is readily available at their sites. The second type of assays that we're using are the functional assays. And functional assays are great because they have a high sensitivity and specificity for this disease so far. They certainly are the best tests for heparin-induced thrombocytopenia. And the success of functional assays is because they follow the pathophysiology of the disease, which is basically antibodies in the circulation that can activate the platelets. So functional assays do exactly that. They measure the platelet activation in the presence of patient serum with donor platelets and upon the addition of exogenous antigens such as heparin or PF4. Functional assays would be are more specific than immunoassays because they detect only the subset of antibodies that can induce platelet activation and not just antibodies that bind to the antigen, which might be benign. One of these functional assays that we're using is the serotonin release assay, which was developed by our group several decades ago. And then a few years ago, we modified that serotonin release assay by adding exogenous platelet factor 4 to the test. Lo and behold, this has proven to be very useful for VIT since the antibodies are believed to be against platelet factor 4 alone and not with heparin. In these assays, various concentrations of exogenous heparin or exogenous PF4 are added to heat inactivated patient serum, and those are added to donor platelets that are radio-labeled with serotonin, radioactive serotonin. And upon the platelet activation, the radioactive material is secreted from the cell, and that radioactivity is quantifiable. The major disadvantage of functional assays is that they're technically demanding. They require fresh reactive donor platelets. They require radioisotopes and a high technical expertise. These reagents and methods are impractical for most clinical laboratories and restrict the use of functional assays to a small number of reference labs worldwide. Fortunately for us in Canada, we have a lab right here at McMaster that is conducting these tests and providing this service to the country. So for our current testing algorithm, it's actually based on a lot of the testing that we do for heparin-induced thrombocytopenia. As soon as a sample arrives to McMaster and is suspected of vaccine-induced clotting, we immediately conduct 3 versions of the screening ELISA test. The commercial one that is available, and it detects IgG, IgA, and IgM antibodies against PF4, and 2 in-house assays that detect IgG antibodies either against platelet factor 4 alone or platelet factor 4 complexed with heparin. If all 3 of these tests are negative, we report the results to a physician that they can exclude VIT within, and this typically happens within 24 hours. If one of these tests is positive, we immediately move on to the functional testing. We do this test in 3 formats also, without the addition of any antigens or with the addition of either heparin or PF4. Again, if the functional tests are all negative, then VIT can be excluded. However, if any of these tests are positive, and if platelet activation can be stopped with the proper inhibitors, then we inform the physicians that there is a high likelihood of VIT. This process takes about 48 hours. In all cases of these results, whether positive or negative, we ask the physicians to report these adverse effects to public health and other health authorities. So I'm going to show an example of one sample that was tested in our laboratory. And what we see here for suspected VIT, and what we see here on the left-hand side is the titers of the antibodies in this patient using all 3 formats of the ELISA test, and they were all positive. This prompted a reflex test using the functional serotonin release assay, and that's the figures on the right-hand side. When the SRE was done in its typical format, as we see in panel A, and this involves the addition of heparin in a dose-dependent manner, the results of the VIT was weak platelet activation compared to a typical HIT patient, which we can see in panel A colored in blue. However, when the test was done with exogenous addition of PF4, which is the suspected antigen for VIT, as we can see in panel B, there's a clear and very strong dose-dependent platelet activation. It's very important to note that this reactivity was inhibited with the addition of IVIG or a control monoclonal antibody that implicates the expected platelet activating mechanism, which is through the antibody. It's also very important to note that samples from this patient on days 3 to 5, after the initiation of IVIG treatment, quickly started losing reactivity. And that's exactly why we ask physicians to draw samples before the initiation of these therapies. Of course, there's nothing that is possible without a great team, starting with my friends, Dr. Kelton, Dr. Arnold, for their leadership and their mentorship, and our diagnostic and research groups at the McMaster Platelet Immunology Lab. Thank you for your attention.
Thanks so much, Isaac. Again, we're getting lots of questions about testing, some of which we'll end up maybe taking live after the talks are done. But thank you for that great introduction to lab testing. It's my pleasure now to introduce Dr. Ted Warkentin. Many of you know Ted, of course. He is a clinical and laboratory hematologist and transfusion medicine director at the Hamilton General Hospital and professor in the Department of Pathology and Molecular Medicine and Medicine at McMaster University. Dr. Warkentin devised the 4T score, a scoring system widely used for heparin-induced thrombocytopenia and identified a syndrome that's remarkably similar to VIT called spontaneous HIT syndrome, and other examples of autoimmune HIT. So it's really we're really very lucky to have Ted to be able to talk about the parallels between VIT and heparin-induced thrombocytopenia, and I'm sure that will generate lots of discussion later. Ted, over to you. Thanks.
Great, thanks, Donnie. I assume you can hear me. So some of you will have seen this interesting paper describing this syndrome that we call VITT. And you may have noticed this unusual phrase, clinically mimics autoimmune HIT. And so my goal today is to explain to you, what do we mean when we talk about classic HIT, autoimmune HIT, spontaneous HIT syndrome, and VITT. And really, there's a theme here. These are all anti-PF4 platelet activating disorders. So that's the common theme for all these conditions. I'm going to touch on why IVIG is important. And I'm going to end with the concept that there's kind of a cool mnemonic or memory device for how VITT, the name, can help you with thinking about the recognition of the syndrome. Well, let's start with classic HIT. So you put a patient on heparin. Beginning around day 6, you see a platelet count fall. You stop the heparin, the platelet count generally recovers fairly quickly. And if you happen to re-give heparin when the patient still has antibodies, you can see an abrupt drop. So we call this typical onset HIT, rapid onset HIT. These are the classic disorders.
I wonder if we've lost Ted there for a minute. Liz, are you seeing Ted frozen as well? Or
yes, he's frozen. Maybe do we want to go to Dr. Pai?
Yeah, maybe we'll do that. Ted, I'm not sure if you could hear us, but your screen is frozen for the moment. So we're going to kind of put a pause on you for a minute and come back to you in just a second. Ted, we'll come back to talking about HIT and its similarities with this vaccine syndrome. But for the moment, we're going to move over to Dr. Menaka Pai. And it's my pleasure to introduce Menaka, a close colleague here at McMaster. She's a hematologist and thrombosis medicine specialist, head of service of benign hematology at Hamilton Health Sciences, and associate professor in the Department of Medicine at McMaster University. Dr. Pai is a member of the Ontario COVID-19 Science Advisory Table and led the development of provincial guidelines for the diagnosis and management of VITT. And I've tasked Menaka with giving us kind of an important talk on diagnosis and specifically management for boots on the ground physicians who may encounter this rarely, but have to look out for it. Over to you, Menaka.
Thank you, Dr. Arnold. We'll get our boots on the ground and we'll do it really efficiently. So I'm just going to start by saying I have no conflicts of interest to declare. So I'm going to walk you through the diagnosis and management of this condition. There are a number of really excellent living guidance documents that address this issue, but today I'm actually going to be referring to guidance from Ontario's COVID-19 Science Advisory Table. And the reason why I'm doing that is because it's really uniquely tailored to the North American context, particularly the Canadian context. And it has input not just from hematologists, but also public health experts, internists, family physicians, and emergency medicine physicians. I know there's a really diverse audience here today, and we've tried to capture all of your unique challenges. So it's important to remember that VIT is a serious adverse event. So as Dr. Arnold mentioned, early reports are stating a case fatality rate up to 40%, and the symptoms seem really scarily common. But we need to remember that the syndrome itself is rare. So it's vital not just to rule VIT in so you can quickly start life-saving treatment, but also to rule VIT out, because if patients don't have it, you don't want them to be exposed to unnecessary diagnostics or treatments, and you want to care for what's actually driving their symptoms. So this is why the Ontario guidance approaches the problem in 3 stages. So first, a patient may present to any healthcare setting, from their family doctor's office to the emergency room to the pharmacy, and they may present with nonspecific symptoms. And then if it is suspected, based on some fairly straightforward workup, the patient can be moved to an acute care setting for advanced tests and imaging. A presumptive diagnosis should then have specialized confirmatory testing done and receive empiric treatment while we wait for that confirmatory testing to come back. The first step in working up VIT, like anything, is really to listen to the patient's story. Though the symptoms seem very non-specific, all reported cases seem to follow a very clear pattern. So we know that CSVT, or cerebral vein thrombosis, has received a lot of media attention, but VIT can actually present with both arterial and venous clots. And there's definitely been a preponderance of clots in unusual sites like CVT or splanchnic thromboses. But we do want clinicians to note more pedestrian clots too. So stroke, acute coronary syndrome, acute limb ischemia, PE, or DVT. The timing is also very important. So Dr. Warkentin is going to outline that this is an immune reaction. It takes time to rev up. So symptoms tend to present between 4 to 28 days post-vaccination. So when you see that combination of typical symptoms in a typical time frame, that should raise your clinical suspicion of VIT. You can move from a suspicion to a suspected diagnosis by focusing on basic workup. And we have recommended tests with a high negative predictive value to help you with that rule out. The key steps at that first stage: confirm the symptoms, confirm the timing, and draw a complete blood count. Now, the platelet count of reported cases has ranged between 10 and 110 times 10 to the 9th per liter. We don't know how far the platelet count fell from the patient's baseline in these cases. But what I think we need to remember is that at diagnosis, the median platelet count of these VIT patients was around 20 to 30. So if the patient's platelets are clearly not decreased, that we feel is sufficient to rule VIT out and to work up the patient for other diagnoses. But a low platelet count, and often an impressively low platelet count, that keeps the diagnosis in play, and it allows you to label the patient with suspected VIT. The next step is to focus on more advanced tests, including the D-dimer, the blood film, and appropriate imaging. And in speaking to practitioners around our province, we feel this is a very tough panel of tests to get in an outpatient setting, and this is why we recommend that it be done in a hospital setting. We know that VIT appears to be associated with systemic coagulation activation. So you're going to see D-dimer elevations generally over 2,000, nearly always over 4,000 micrograms per mil, in fact. The Ontario algorithm does not require any other coagulation testing, but it's been noted that the fibrinogen, the PT, and the PTT are generally decreased too. The blood film is really important to rule out procoagulant phenomena that look like VIT. So in VIT, it should only show thrombocytopenia. It shouldn't show, for example, red cell fragmentation like TTP. Imaging is required, of course, to diagnose the thrombosis. This is the sine qua non of this syndrome. I'm not going to review how to diagnose more usual clots today, but I will make a special mention of CVT. It's a really tough diagnosis to clinch. A non-contrast CT brain is a great first step in a patient who has a severe headache or focal neurologic symptoms, because it can show things like, for example, acute ischemic stroke or intracranial hemorrhage. But it is not sensitive enough on its own to rule out CVT if you have a high pretest probability, for example, if you have suspected VIT. So in this case, an MR and an MR venogram may be done. But I'm sure you're all thinking, well, in my center, an MR can be really hard to access. So there's actually a more acceptable, more accessible, and sufficiently accurate option that you can use. You can couple that non-contrast CT with a rapid CT venogram. And I have to acknowledge a colleague, Thalia Field, who's one of Canada's leading stroke neurologists, for really advancing this strategy. So make sure you do your CT and do some venographic imaging too. Once you've done your key diagnostics, once you find that the D-dimer is high, the blood film is pretty bland, and imaging shows a clot, you now have a presumptive diagnosis of VIT. And you can actually move on to what I think are the really essential steps: hematology consultation and the testing that my colleague, Dr. Nazy, outlined. Now, as he mentioned, you must order an enzyme immunoassay to look for the VIT antibodies because the rapid assays don't appear to be sufficiently sensitive. These assays and then confirmatory functional testing should be sent before you give IVIG. A hematologist or thrombosis expert can guide you with testing, and we can also guide you with that initial empiric treatment. Now, the first step of that treatment is anticoagulation. We're recommending that you avoid heparin and you avoid platelet transfusions, as both could theoretically add fuel to that prothrombotic fire. Now, certainly in Ontario, we have real disparities in how well different healthcare settings are resourced. I believe that's the same across North America. So that's why we suggest that first-line anticoagulation should be the easily accessible direct oral anti-10A inhibitors at full treatment doses. Now, obviously, if the patient is too unstable for oral agents, if the renal function is impaired, if you have concerns about bleeding, which can be a problem with CVT, but not a contraindication to anticoagulation, that's when a hematologist or thrombosis physician can guide you around parenteral anticoagulants. Administration of IVIG is really essential because it likely impedes antibody-mediated clearance of platelets. It raises the counts. It impedes platelet activation by blocking platelet FC receptors, so it dampens down the thrombogenic state. We recommend an actual body weight-based dose of 1 gram per kilogram daily for at least 2 days. Now, importantly, whether you diagnosed VIT or you simply have an unrelated thrombosis or thrombocytopenia, it's essential that you report to public health and to your jurisdiction's regulator. We really depend on surveillance of vaccine-associated adverse events. It's really the foundation of vaccine safety. And finally, as I close, it's really miraculous. VIT was just discovered in March, and now with global scientific cooperation, we have learned so much. This is a treatable condition, especially if recognized early. There are certainly many remaining questions. As hematologists, we are certainly willing to step up treatment to steroids, to plasma exchange, but exactly where they fit into the treatment algorithm is the moving target. We are learning more about how long VIT antibodies persist, but the clinical relevance of that persistence, it's also an open question. You know, how do we monitor patients at discharge? Certainly, our regulators are working hard worldwide on what to do with the second dose of the vaccine in patients who've had VIT with the first. And we were very grateful to hear from Dr. Nair about the 6 credible cases of thrombosis and thrombocytopenia reported in the US. So learning more about the pathophysiology of VIT with these different adenoviral vector vaccines is essential. I'm going to leave you with a link to your right. This is some information that you or your patients can refer to if you have questions about VIT. Our science advisory table has produced both scientific and lay summaries, including brief guides for primary care and emergency medicine colleagues. These are continually updated resources. So I thank you for your time and turn it back over to you, Dr. Arnold.
Thanks so much, Dr. Pai, for an excellent overview and practical information that's so valuable for all of us. I'm hoping Ted is back online. I see his image there, which is promising. Maybe we can get you back to the slide that you ended off at. Move you forward just a little bit. There we go.
Okay, so apologies, I assume you can hear me.
Yep.
So we were talking about classic hit, and the point is, if you look to the right, that you see heparin-dependent antibodies in the case of classic hit. And so classic hit is characterized by these special immune complexes. You can see the heparin, the long yellow sulfated polysaccharide binding to this highly positively charged protein, platelet factor 4. And these complexes are recognized by antibodies that interact with FC receptors and cause clustering. So this is the concept of HIT. And so if we think of HIT as this group of disorders, well, autoimmune HIT, it represents a subgroup where you have both heparin-dependent antibodies as well as heparin-independent platelet-activating antibodies. And so when you do the serotonin release assay in the McMaster lab, you have this interesting phenomenon where even in the absence of heparin, you see strong serum-induced platelet-activating properties. This is the essence of what we refer to when we talk about autoimmune HIT. And so here's a quick example. Here's a patient who went home after heart surgery. So I hadn't been on heparin for over a week. Platelet count is 61. Repeat is still low. comes back to hospital, is found to have pulmonary embolism. And notice the platelet count is 72. This is a month after the heart surgery. This patient gets fondaparinux, gets sent home on rivaroxaban, and the platelet count very slowly recovers. Basically, this is HIT that goes on for weeks and weeks. And on top, you see the serotonin release assay. And when I show you the result in the absence of heparin at 0 units per mil heparin, you can see gradually falling heparin-independent platelet activating effects that parallels inversely the gradual recovery in platelet count. So you can see it's this very abnormal heparin-independent platelet activating properties that explains this unusual picture of HIT. And so basically the way to think about autoimmune HIT is it's the same disorder. The only difference is take away the heparin. This would be the same slide without the heparin there. These antibodies either are able to engage PF4 without any polyanion or perhaps polyphosphates or chondroitin sulfate or other so-called platelet-associated polyanions. So it's a highly pathological antibody. All right, so that's the concept of autoimmune HIT. And the 4 syndromes we talk about are delayed onset HIT, like the case I showed, or persisting HIT. It also had features of that, or heparin flush HIT, or fondaparinux HIT. These are 4 so-called autoimmune HIT disorders. Now let's shift that curve a little bit to the right, and that's to indicate that there's a tiny, tiny group of patients who have autoimmune HIT, that is, they have antibodies that activate platelets in the absence of heparin with PF4 reactivity, but without any preceding heparin. And we call that the spontaneous HIT syndrome. And there's 2 variants, the post-knee replacement surgery, spontaneous HIT, and the medical, which are usually post-viral, post-bacterial. And here's a slide just showing how rare the so-called medical spontaneous HIT syndrome is. I could only find 10 cases in the world's literature, but look at them. 4 of them had CVST, 2 of them had arterial stroke, so 60% of the reported so-called medical spontaneous HIT syndrome patients had stroke. And I think there may be a lesson there as to what the VIT syndrome is doing. And in fact, that's the way one can think about the VIT syndrome. It is basically not heparin, but it's triggering, just like knee replacement surgery can trigger, or like some infections rarely trigger a syndrome directed against PF4. Now, why IVIG? Well, there's a lot of experience now using IVIG to treat HIT. You can read about it in this open access paper. Here's the historical time frame for using IVIG to treat HIT. And you can see that since 2017 onwards, there's been a recognition that IVIG is very good at rapidly de-escalating these unusual cases of autoimmune HIT with the strong heparin-induced platelet activating property. And so here's just an example. This is one of these post-knee replacement HIT cases. This patient never got heparin. This was the patient received aspirin prophylaxis. And this patient actually had splanchnic vein thrombosis, again, showing these unusual autoimmune HIT disorders can have unusual thrombi like splanchnic vein thrombosis. And look at this. This patient received IVIG, and within 3 days, the platelet count went from 21 to 200. And look at the top, the rapid drop in the heparin-independent platelet activating properties. And this is what emerging data is showing is happening when the VIT patients are treated with IVIG. So this is my last slide. I mentioned I would suggest a mnemonic, and this is what I teach the residents. I say, think of the name VITT. So you get the vaccine, one of the adenoviral vector vaccines, and the I you can think of as the interval. So I know one of the slides said day 4. It turns out that was an initial report that was later changed to after day 4. So the earliest case yet reported is actually day 5, and that fits the rule of HIT, which is day 5. So the interval ought to be any thrombotic event starting between day 5 and let's say up to day 30. So that's the interval. Then you see a thrombosis. Of course, you investigate rapidly with platelet count and D-dimer. If you see thrombocytopenia, that is a pretty important clue that your patient may have VITT. So this is a mnemonic I wanted to end my presentation with. And sorry about the technical issue there. And thanks, Menaka, for saving me, as she usually does here at the Hamilton General. Thank you very much.
Thanks so much, Ted, and all the speakers. That was really very comprehensive overview of an rapidly evolving disease. There have been a lot of excellent questions in the chat. I'm going to try to address some of them kind of at a high level and grouped a bunch of them together. We're going to go through this fairly quickly because there's only about 5 more minutes. There's a lot of questions about, are there risk factors for VIT? Are there patients in whom you should not want to necessarily give the AstraZeneca vaccine? Menaka, I'm going to look to you first. Do you want to try to take a stab at that?
Sure, I'll try. So certainly there seems to be a preponderance of younger people, preponderance of women. Tough to know whether that's a true association, tough to know whether this is selection bias, because most rollouts focused on that population first. And we do know women are more predisposed to even to HIT, for example, and also to immune phenomena. Right now, though, in terms of risk stratification, we know cases have appeared at all ages, in all genders. Right now, our regulator, Health Canada, suggests that AstraZeneca be avoided, not contraindicated, in patients with a history of HIT and with a history of CVST. So that's sort of the official word. Epidemiologic studies are moving very, very fast, Johnny.
Yeah, good. I think that's a moving target as well, but excellent. Dr. Nair, if I could ask you a couple of questions. So there are a few questions about vaccine use in the US. Why was AstraZeneca not approved in the US? And second, what do you think about Canada reducing the age limit to 40 for AstraZeneca vaccinations in Canada?
Yeah, thank you for the questions. And I can't really speculate on Canada's approach to AstraZeneca. As I mentioned, it's not licensed or authorized for use in the U.S. and it hasn't been submitted. An emergency use authorization hasn't been submitted in the U.S. So there hasn't been a case where it's been submitted and it wasn't authorized. They haven't submitted that as of yet.
Okay, perfect. Ted, over to you. There's a bunch of questions about, does this antibody get worse with heparin? What's the effect of heparin on this antibody? So speaking maybe in vitro, but also in vivo, is there a big concern about giving heparin to patients with VIT?
Well, because it's such a tricky diagnosis to make, undoubtedly some patients are going to get heparin. And so we're actually looking at some of those cases quite carefully. And I must say, sometimes the platelet count actually rises on heparin, and it may well be that heparin works. It's just because it's HIT mimicking and because we don't have a lot of data right now, the jury's out. And I guess for safety sort of reasons, we're trying to avoid heparin. But it might well be that these unusual antibodies are targeting a site on PF4 that clearly was triggered in the absence of heparin. And maybe if you give heparin, you actually change the conformation that it's less reactive. So I wouldn't be surprised, 30 years of HIT, lots of paradoxes. I wouldn't be surprised if heparin turns out to be safe and effective in VIT, but right now we don't know, and we're suggesting non-heparin anticoagulation for now.
Super. Dr. Nazy, lots of interesting questions about the biology. Something about an adenovirus vector that might be stimulating this immune response. Is there a precedent for this? There are certainly other adenovirus vectors, vaccines out there. Has this been described before? And what can you postulate that could possibly be the mechanism?
I've been following some of the questions that appeared in the Q&A box. Anti-PF4 heparin antibodies do not seem to have appeared in previous adenovirus vaccinations. Of course, there's never been a mass vaccination at this level with an adenovirus before. So if you were to do one at this level, there might be, who knows. There were some questions as to how the immune response could have been induced. Does PF4 interact with the spike protein? And our preliminary evidence in the lab, PF4 cannot bind the spike protein. So it could not be the driver of that immune response from that. Now, getting a vaccine with an adenovirus could induce a pro-inflammatory state, which could lead a variety of B cells to be induced. And part of them could be anti-PF4 antibodies that could, in some people, lead to this.
Excellent. There are so many more questions that I think we could spend easily another hour answering them. I'm going to turn the last minute over to Dr. Crowther and see if he wants to make some final statements, maybe about some of the questions he's seen or stuff that he's heard today, or some comments in general. But
yeah, just thanks, Donnie, and thanks everybody for attending. Amazing number of questions, 181 of them so far, many very similar. Just maybe I'll summarize, ask one question of Ted or Menaka, perhaps. So there's been a whole bunch of questions on whether, given that the issue of heparin is unknown, for people who require hospitalization, is fondaparinux a reasonable intervention? Any reason to not use fondaparinux?
I'm going to turn that over to Ted because he's been, I think, quite a pioneer in fondaparinux treatment and HIT. So you get this one, Dr. Warkentin.
Well, yeah, I mean, we're actually, there has been fondaparinux used. I guess there's a little caveat in that some of these spontaneous HIT cases and autoimmune HIT cases, I should say, have had fondaparinux cross-reactivity, which is a rare phenomenon. But that is a rare phenomenon, and so I think to me, what you want to do is pick whichever anticoagulant you think, given the patient's particular circumstances, is the best anticoagulant. And given how little experience we have, I think that's your best bet. What drug do you have most confidence in, and not worry about theoretical considerations?
Thanks, Ted. And on those lines, just to close, I'd like to, first of all, just repeat the message that I think we should all be getting out, that vaccination is the key to getting rid of this disease. The complications of getting COVID, the risk of thrombosis, the risk of worsening platelet counts, is vastly higher if you get COVID. Severe COVID illness, hospitalizations, and critical illnesses largely eliminated by the vaccines we have available to us. So the message for everybody should be to get vaccinated as quickly as you possibly can, and then we can have long discussions afterwards about this complication. If we don't get people vaccinated, there's going to be a lot more thrombotic complications because of the consequences of COVID. In closing, we're a bit over time. I'd like to thank our speakers today for an excellent set of rounds. I'd like to thank the members of the Food and Drug Administration of the United States who participated and for providing some of the specific information that was very helpful for both us and the attendees. And also thanks to Ms. Liz Goldstein and other members of the Anticoagulation Forum for hosting this webinar. A note that the webinar has been recorded and it will be posted along with the slides at some point in the next couple of days on the Anticoagulation Forum website, which you can find by just typing that into Google. So in closing, I'd like to thank the speakers again, thank the attendees, and really excellent session from which I think we've all learned an awful lot. Thanks very much.